I have the pleasure of welcoming you to the 4th edition of the National Guidelines for Diagnosis and Treatment of Malaria under the auspices of the Nigeria and Entrepreneurship Summit and Honors. And the founder is here with us, Mr. Ugoju. You're very welcome, sir.
Thank you.
But first, a few housekeeping rules before we go straight into the program. The guests will be unmuted when the panel session is ready. The audience will also be unmuted for the question and answer session. Otherwise, can we all kindly keep our microphones muted so that there'll be no interference? And if there's any extraneous source of noise at your location, please minimize it, and also please mute until the noise abates. We will continue to update you on the different guidelines as we go along. But now, ladies and gentlemen, may I ask that we all virtually stand for the national anthem. The national anthem. The opening prayer will be the words of the second stanza of the national anthem. The second stanza of the national anthem. O God of creation, direct our noble course, guide our leaders aright, help our youth to truth to know. Love and honesty to grow, living just and true, great lofty heights attain, to build a nation where peace and justice shall reign. Amen. Thank you very much for the anthem. We will now have the welcome remarks of the founder of the Nigeria and Entrepreneurship Summit and Honors, the acronym for which is NESH, NESH. Mr. Emeka Ugoju is one of the most self-effacing people I have ever met. If you catch up with him, he drives himself, and he's a man of very, very humble aspect. He doesn't even like to be spoken about or spoken of. But sir, the floor is now yours for your welcome remarks to this 4th edition of the National Guidelines for Diagnosis and Treatment of Malaria. Mr. Emeka Ugoju, the floor is yours.
Can you hear me?
Yes, we can hear you, sir.
Okay, so I can start.
Please commence.
Okay. The Permanent Secretary, Federal Ministry of Health, Madam Abdullahi, presented National President, Association of Local Governments of Nigeria, and the co-host, Honorable Kolade Alabe, who was recently re-elected to a new term of 3 years. The Director General, Nigerian Governors Forum, Association of Kauru, the General Manager, External Relations and Sustainable Development, NLNG, panelists and gentlemen. Greetings and compliments of the Easter season. On behalf of Nigerian Partnership Summit and Others Foundation, the National Malaria Elimination Program, Federal Ministry of Health, I heartily welcome all of you online to this NESH NMP seminar on the 4th edition National Guidelines for the Diagnosis and Treatment of Malaria. On 21st September 2020, NESH, in partnership with the Nigerian Governors Forum and ALGON, and in collaboration with National Malaria Elimination Program, hosted a National Health Roundtable with the theme, Public Health Management in Nigeria, with special focus on malaria, tuberculosis, Lassa fever, and COVID-19. Prince Julius Adelusi Adelui, OFR, a former Federal Minister of Health, was the chairman of the occasion. Many stakeholders from the health sector participated in the event, and the National Assembly was represented by the Chairman Senate Committee on Primary Health and Communicable Diseases, Senator Chukwu Kautazi. At the roundtable, the Minister of Health, Sagi, represented by the Minister of State for Health, Senator Adeleke Mamora, sorry for the brief interruption. Please use this opportunity to speak about a new and innovative public-private partnership program, the Tech Malaria Charity Outreach Program, which will commence nationwide on 1 Day 2020, and is being promoted by NESH and Wabio Foundation in collaboration with ALGON. The Test and Treat Malaria Charity Outreach Program, as conceived, will be supported by corporate Nigeria, parastatals, publicity, Nigerians. I will deliver simple and convenient NAFDAC-approved do-it-yourself urine malaria test kits and anti-malaria ACT medicines for free to rural and urban poor Nigerians nationwide, who are now experiencing rising cases and deaths from malaria. This program will help in significantly reducing deaths from malaria attacks, especially amongst children. It is also part of our 5-year strategic advocacy program of encouraging the private sector to play an active role towards improvement of primary health care in the country. Primary health care is a major responsibility of the local governments, and the president of Association of Local Governments of Nigeria, who is the co-host, may have something to say about the proposed public-private partnership. Once again, I welcome all of you, wish all of us a very productive seminar. Thank you.
Thank you very much for that concise speech. The aim is to save lives. particularly of children. Now we will come to goodwill messages and all protocols duly observed. May I respectfully invite Senator Dr. Ibrahim Yahaya Oloriegbe, the chairman of the Senate Committee on Health, or his representative, to give a short goodwill message. Senator Oloriegbe, most distinguished. I have been made to understand that the distinguished senator is not yet on the program. We'll be expecting him. Meanwhile, I would like to invite a colleague of mine who we have worked together for very, very many years, even though I'm in the private sector and she is in the public sector. Ladies and gentlemen, I have the pleasure of inviting Dr. Olowu. I think she has been nominated to represent Malam Abdulaziz Abdullahi, the Permanent Secretary, Federal Ministry of Health. Dr. Olowu is in charge of diaspora-related health matters. She will give her designation fully when she comes on. Dr. Olowu, it's good to see you again. Welcome. The floor is yours.
Thank you very much, Dr. Leke Oshimi. Good to see you again. Good morning, ladies and gentlemen. I'll start by acknowledging Mr. Emeka Ogu Oju, the Chief Executive of the Nigerian Entrepreneurship Summit and Honor, the President of Algon, the National President Algon, Mr. Kolade Alabi, and the representative of the Nigerian Governors Forum on this platform. In absentia, let me recognize our distinguished Senator Oloriegbe, who is the chairman of Senate Committee on Health. My name is Dr. Omobolanle Olowu MNI. I'm here on this platform representing my permanent secretary, Malam Abdulaziz Abdullahi, who coincidentally is attending this would have been his third assignment within the same time period. So he graciously said I should represent him on this platform. So I'll read his remarks and I also say apologize on his behalf for not being able to attend this very important meeting, which we consider in the health sector very important to us. So I'll read his remarks as he has written it. You only hear my voice, but you are listening to what he has written. Thank you very much. It gives me great pleasure to be a part of this important and pertinent online seminar geared towards creating awareness on the national guidelines for diagnosis and treatment of malaria. As you may be aware, malaria is still a public health challenge and is a major cause of morbidity and mortality in Nigeria. Nigeria alone contributes about 27%, that is quoting WMR of 2020, of the global malaria cases, and 23% of the same WMR 2020 of global malaria deaths. Over the years, intensive and dedicated program implementation by government and partners have brought a reduction in malaria prevalence from 42%, that is as at 2010, to 27% as at 2015, to 23% in 2018. To sustain these gains, we call on all stakeholders to continue to ensure adherence to the national guidelines on diagnosis and treatment of malaria. The guidelines, which was recently updated, would recommend testing all suspected malaria cases before giving the recommended treatment of artemisinin-based combination therapy, ACT, for those who test positive. The federal government has since banned the use of monotherapies for the treatment of malaria in Nigeria. Hence, it is criminal for any health worker, both in public and private healthcare facilities, to be found prescribing such. The guidelines also provide direction on the management of severe malaria, chemo prevention of malaria in targeted groups, and chemoprophylaxis in at-risk groups. For reductions in malaria burden and deaths, the National Malaria Elimination Program, in collaboration with partners, have developed the new malaria strategic plan spanning 2021 to 2025. The new plan's goal is to achieve a parasite prevalence of less than 10% and a reduction in mortality attributable to malaria to less than 50 deaths per 1,000 live births by 2025. The country requires a total of 1.9 trillion naira to implement this plan successfully. Distinguished ladies and gentlemen, we know that this is a huge task for the government, particularly when you consider the fact that the economies of most countries, including Nigeria, have been affected negatively by the COVID-19 pandemic. We are presently looking at innovative ways to increase domestic resources for malaria through the development of advocacy briefs, holding legislative dialogues, setting up of an End Malaria Council, soliciting increased state government support for malaria, taking advantage of strategic and innovative financing mechanisms that are present in country. We are equally looking towards the organized private sector, such as the Corporate Alliance on Malaria in Africa Group and other multinational corporations, including NNLG, ExxonMobil, the Dangote Foundation, and so on, and wealthy philanthropic Nigerians and the manufacturing industry for support to bridge the gap in funding for malaria. Distinguished ladies and gentlemen, let me remind us all that on the 25th of April, 2021, Nigeria will be joining the rest of the world to commemorate World Malaria Day. We will use the opportunity to create awareness on the negative impact of malaria on the health and socio-economic development of our country, and mobilize all decision makers, private sector players, and youth towards malaria elimination. May I also inform you that the 4th edition of the National Guidelines for Diagnosis and Treatment of Malaria emphasizes the importance of parasitological confirmation of malaria cases, either through microscopy or rapid diagnosis tests before treatment. It provides step-by-step guidance in carrying out the diagnostic procedures. I encourage all public health practitioners to get a copy of the guidelines. Finally, I cannot conclude without expressing my gratitude to all the malaria partners that have consistently supported malaria elimination in our country. I also thank Dr. Emeka Ogbujoju and the entire Nigeria Entrepreneurship Summit and Honor team for making this online seminar a reality. I wish you all a fruitful and robust deliberations. I thank you for attention and may God bless you all. Thank you very much.
Thank you very much, Dr. Lowu. Those are frightening figures you have given us. 27% of the global malaria health burden, 23% of the global malaria deaths in one country, this country, and a requirement of 1.9 trillion naira to implement all the guidelines we need to conquer this dread disease. Thank you very much, man. And please thank the Permanent Secretary for attending this seminar. We thank you very much.
Thank you.
I am informed that of the arrival of one of our big masquerades, Senator Abdulaziz Oloriegbe, the chairman of the Senate Committee on Health, has now arrived. If he doesn't mind, we'll just go straight and take his goodwill message. Goodwill message from Senator Abdulaziz Olorebe, Chairman, Senate Committee on Health. Most distinguished, sir, you have the floor. I don't think Senator Olorebe is Dr. Ibrahim Yahaya Olorebe, Chairman, Senate Committee on Health. Okay, perhaps the chairman has not settled in fully. Can we have the goodwill message from Mr. Okaru, the Director General of the Nigeria Governors Forum? Okay. I thought I saw him on the panel, the DG of the Nigeria Governors Forum. Is he with us?
Can you please just take the next one while the DG settles in?
I beg pardon?
I said, can you just take the next person while the DG just settles in?
Okay, so Honorable Kolade David Alabi, the National President of the Association of Local Governments of Nigeria, ALGON. You're very welcome, sir. Can we have a goodwill message? Most respectfully from your good self. Okay. If we do not have the National President of ALGON with us, then we'll take Mrs. Eyono Fatai Williams, the General Manager, External Relations and Sustainable Development of NLNG. Mrs. Eyono Fatai Williams. Okay, perhaps now might be the time for the interview so that we can see the advertisements from our sponsors while we wait for goodwill messages to come up on the platform. An interlude for adverts from our sponsors while we wait for the goodwill messages.
Shebi, you say you dey find ogbonge and reliable way make you take test for malaria. Oya, no shake go front again. We don introduce the all-new urine malaria test wey they call UMT. The first and the only non-blood dipstick wey you fit take test for malaria. Within 25 minutes, you go check whether na fever or na malaria dey do you. No blood, no pain, na just small drop of urine wey you need. How this UMT strip take dey work? Number one, you go deep test the strip inside one small cup of urine. Number two, make you wait small for that kind 25 minutes or less. Then number three, if you see two line, na be say you get malaria. If na one when you see, na be say no malaria there at all. But if you not see any line appear, that one mean say the test not correct. So you go take another strip, make you do another one.
Children are gifts and the source of joy. When they're happy, we're happy too. But when they're down with sickness such as malaria, we become sad and worried. Not to worry, Camosunate anti-malarial for children has always been there for years. Camosunate also comes in tablets for adults. Bounce back from malaria with Camosunate. Confirm if Camosunate is original by texting to read the leaflet inside. If symptoms persist after 3 days, please consult your doctor. Camosunate, effective anti-malaria for all ages. Marketed by Zenith Pharmaceuticals Limited.
Shebi you say
Ladies and gentlemen, I think we now have the senator on the platform. I just saw his name scrolling. The very big masquerade has come to honor us on this platform today. Senator Dr. Ibrahim Yahaya Uluegbe is the chairman of the Senate Committee on Health. Most distinguished, sir, are you ready to give your goodwill message? If so, you have the floor, sir. Okay, there seems to be a technical hitch there. Can we take the Chief of Staff of Honorable Kolade David Alabi, the National President of the Association of Local Governments of Nigeria, in the person of Chief of Staff Itiakpo Ipopo, the Chief of Staff of the President of Algon, Honorable Alabi, will give the goodwill message on behalf of the President of Algon. Okay, well, we may have to move on with the program while the messages are getting ready. I propose that we take the presentations on the fourth edition of the National Guidelines for the Diagnosis and Treatment of Malaria. I am professionally very interested in this presentation. Not many people know that it is a criminal offense. That monotherapy for malaria is a criminal offense. The medical community will take the presentations on the fourth edition of the National Guidelines for the Diagnosis and Treatment of Malaria, starting now.
So good morning, everybody. Good morning, everybody.
Good morning, madam.
Okay, good. Standing
Good
on
morning,
existing
madam.
protocol. Standing on existing protocol. My name is Dr. Nenna Obulafor, and I'm the head case management branch of National Malaria Elimination Program in the Federal Ministry of Health. I'm taking this presentation on behalf of the National Coordinator, Dr. Perpetual Uhubimo, who is unavoidably absent on another official assignment. So I want to, continue to appreciate the organizers of this seminar, NESH seminar, for their consistency and the interest on malaria. I just wanted to put through that last year we had a similar thing when the Honorable Minister of Health launched the national guideline, the 4th edition national guideline on diagnosis and treatment on malaria through this network to the NESH network last year. So we continue to be grateful to the NESH group. Thank you very much. And then maybe I'll just start the presentation right away. So thank you. Can I have the next page of the presentation? Next slide. Okay, so that's the outline of the presentation. Introduction, background, key recommendations in the guidelines, challenges, and then call to action. Call to action is actually our area of interests for this presentation this year. So for introduction, my permanent secretary already had talked, giving a detailed information on the data from malaria, both in country and globally. But just to say that a major strategy put in place for the control of an elimination of malaria, it's through the case management. And the case management comprises of prompt diagnosis and treatment of malaria cases as recommended and contained in the National Malaria Strategic Plan 2021 through 2025, and also, of course, in the National Guideline of Malaria Diagnosis and Treatment of Malaria. Next slide, please. Can I have the next slide, please? So as a way of background, it's important for us to note that the Federal Ministry of Health, under which the program is housed, has the purview of development of policies, guidelines, and strategies. And so the National Guideline for Diagnosis and Treatment of Malaria has been updated since the last 10 years. It was done in 2011, and then next review was in 2015. And of course, the recent review that happened last year in May 2020, for which we used this platform, for the launching too. And so the guideline is in line with the recommendation of the 3rd edition of WHO treatment guidelines, and also the malaria program review. The malaria program review that was done early last year, as well as the therapeutic efficacy studies that the program does on yearly basis, to monitor and keep touch of our deployed medicines, for the country on malaria. Next slide, please. So key recommendations, as enshrined in the guideline remains, one, it recommends parasitological confirmatory tests. So it then means that before you can treat any fever or you can treat malaria per se, you must have done a parasitological confirmatory test. And these confirmatory tests, it's either through microscopy, rapid diagnostic test kits, or the UMT. And so that's when it emphasizes prompt parasitological confirmation through microscopy, RDTs, and UMT in all patients suspected of malaria before treatment is initiated. And of course, this must be quality assured, as well as the products, the RDT and UMT must be quality assured. And so it's important that the source where these test kits are gotten must be assured. They must have been, quality assured. That's what it means. And of course, the microscopist must have been, must be expert microscopist. It means that they would have, been trained and retrained, on how to identify parasites, as to make a diagnosis of malaria in the laboratories. And of course, clinical diagnosis should only be considered in children under 5, where parasitological diagnosis is not accessible. As we speak, almost all over everywhere in country, even in the remotest places of the PHCs, we have the rapid diagnostic test kits available. Is that fevers must be tested before ACTs are initiated. So on the treatment, what are the key recommendations according to the guidelines? So we have artemisinin-based combination therapies, which we call ACTs, are the recommended treatment for uncomplicated falciparum, P. falciparum malaria. In Nigeria, artemether-lumefantrine has been deployed in the national program together with other ACTs, like the artesunate amlodipine, dihydroartemisinin piperacin, and artesunate pyroneurodine. And of course, just like the permanent secretary said, reiterating his words, artemisinin and its derivatives should not be used as monotherapy in treatment of uncomplicated malaria. Next slide, please. And so for pre-referral treatment for severe malaria, in order of preference, we have in settings where complete treatment of severe malaria is not possible, patients should be given pre-referral treatment and referred immediately to an appropriate facility for further treatment. And so you can see across the slides, you will notice prompt and immediately. So it's important that, issues around uncomplicated malaria, immediate response, should be taken, because if not treated appropriately, especially in the under 5, patients can, immediately deteriorate into the severe form, which is the severe malaria. And that is where the issues, main issues are too, because the patient will then be battling to survive. And so for that, in children less than 6 years, the pre-referral treatment remains rectal artesunate. We can have IV-IM artesunate, IM artemether, and IM quinine. This is in order of preference. So in order of preference, the guideline estimates that artesunate should be the first line of treatment. If there is no artesunate, then artemether can be used, IM artemether can be used, or IM quinine, in that order, for pre-referral treatments. And then for children above 6 years and adults, the option for pre-referral treatment remains artesunate IM, artemether IM, and quinine IM in that preference. Next, please. So on the prevention of malaria in pregnancy, the guideline states that or recommends that sulfadoxine pyrimethamine, which is the usual SP or the normal SP, has been recommended for treatment in pregnant women for intermittent preventive treatment in pregnancy, which is what we call IPTP. And this treatment is usually initiated after the first trimester or when the mother has, or the woman, the pregnant woman would have noticed her quickening. Quickening is the kicking of the baby, about that time, corresponds with the first trimester of her pregnancy. And so the woman is expected to be taking SP every month till birth, while encouraging them to also sleep under the insecticide-treated mosquito net every night. So next, please. On the seasonal malaria chemoprevention, seasonal malaria chemoprevention is also one of the interventions that is being done in the program. So it's recommended in areas of highly seasonal malaria transmission, which is through the sub-Saharan region of the country, and also in areas where greater than 60% of rainfall occurs within 4 consecutive months. So this has, with this, we have expanded the scope of the seasonal malaria chemoprevention, and it's important to note that this seasonal malaria chemoprevention is for children under 5, for prevention of malaria. So the treatment is given throughout the peak period of the rains. Okay, just like we said, in the Sahel area region of the country, and also in areas where we have 60%, greater than 60% of rainfall, within 4 consecutive months. And so these areas has been couched out to be most areas in the north. So we have the northeast, some areas in the northeast, northwest, and the north central. Some of those areas have been couched out to, benefit from the seasonal malaria chemoprevention. And so what we use for this treatment course is the sulfadoxine pyrimethamine plus amodiaquine, which comes as a co-pack, for treatment of under 5s. So like I said, it's given to children aged 3 to 5 months at monthly intervals, beginning at the start of the transmission season, up to a maximum of about 4 doses during the transition season. So if we start sometime in July or June, as the case may be, depending on how we've estimated it within the program, it's expected that that treatment course will run over 4 months for the child to be appropriately protected. This will also help to increase the therapeutic dose of the medicines in the bloodstream of that child, thereby preventing malaria preventing the child from coming down with malaria. So we have the challenges of implementation. Next slide, please. So in the program, we're also battling with a lot of challenges. So we've tried to kind of couch them under certain headings. So we have majorly, in that preference, non-adherence to the national guidelines, which is why we're also doing this awareness through this webinar, the NESH webinar. So we part of the challenges we have, which is one of the major ones, especially around the private sector, which has more than 60% patronage by the general public, in country. So we have non-adherence to the national guidelines. So this non-adherence, it's around presumptive diagnosis. So presumptive diagnosis, it's a situation where a clinical diagnosis is done. That is, a patient is not tested, presenting with fever that comes to a clinic and not tested to know what the cause of the fever is before treatment is initiated. So, this is really very high up there, especially around the private sector, So we also have low testing rates and high positivity rates. So these are all, together, so patients are not exactly tested. They are just being diagnosed through the symptoms that they present to the health professional. And then, of course, a diagnosis of malaria is made without testing. So part of also what we have under that challenge is treatment of RDT or microscopy negative patients with ACT. So it's also all connected. So sometimes when some of these patients are tested and they are negative, for malaria, the health workers also go ahead to also prescribe ACT, which is not the case. So we continue to use this media and through other forums or fora to say that malaria, as much as it's one of the commonest causes of fever, it's not the only cause of fever. There are a whole barrage of causes of fever. And so we continue to stand and to push to the general public, to the healthcare professionals, that all cases of fever must be tested. And when it is negative, they should subject the patients to further tests to know the cause of the fever. Things like infection, simple infection, upper respiratory, lower respiratory, stress, all of them are all causes of fever. And so we need to be treating appropriately, not putting it on malaria, on all cases of fever. And also part of, under that also we have administration of wrong medications, so that's also part of what we have. Like we have in uncomplicated malaria, we have some of the health workers using IM artemether to treat uncomplicated. Like we said, if you remember in the previous slide, we said IM artemether, artesunate, in that order, it's used for severe malaria. So these are all drugs that should be used appropriately, as at when required. And we're saying that artemether are drugs that are used for the treatment of severe malaria and not uncomplicated malaria, as the case may be. And also the use of syrups. So the program does not accept the use of syrups for children. We have dispersible tablets for the treatment of children, under 5, a little above 5, and not with syrups. Also the non-reference to national guidelines and job aids, which is what I've said. So also part of the challenge we have is issues around health workers, issues and challenges around health workers, which includes grocery inadequate number of health workers manning health facilities. So we don't have enough and capable health workers manning health facilities. Capable skills of the health workers is deficient in some instances, especially in laboratory scientists. We also have non-qualified health workers rendering services. For example, a lab technician carrying out a microscopy. Microscopy is supposed to be carried out by a medical laboratory scientist and not a technician in the lab. So these are also part of the challenges that we're having regarding implementation. So part of the challenges also includes issues on commodities and job aids. So non-availability, inadequate of medications and consumables at service delivery points. For example, we don't have availability of even the RDTs for testing, also the stains and slides for the microscopy testing, and also the injection artesunate, which we said is the first line of treatment for severe malaria, which is a severe form of malaria. So these are all non-available in some of the health facilities. Also frequent stock out of ACTs and RDTs, non-availability of job aid standard operating procedures, the SOPs and algorithms for carrying out these tests, and also for giving the medications are all not available in some of the health facilities. Also equipment and also facilities. In some of the facilities, we don't have things like weighing scale, which is things that, equipment that we need, to enhance productivity in terms of management of malaria, And also we also have issues of inadequate source of electricity. Some health facilities don't even have a standby generator, and some of these tests require electricity to be, carried through. Also lack and inadequate facilities for supportive treatment. Example, blood transfusion, ICU facilities. These are in cases of severe malaria. which is very common, like we said, in under fives. And then, of course, laboratory facilities, we have the full blood count machines. Some of them are obsolete, some of them are not working. Microscopes are obsolete, so equipment are not generally, not there in some of the health facilities. Next slide, please. Next slide, please. Next slide. Okay, so we have, sorry. Can you go back on that slide? I'm sorry. I think I was having a weak connection. Okay, good. So part of the challenges, thank you. Stay on that slide. It's also the coordination platforms. We have weak or moribund coordination. Next slide, just the next slide after this. Sorry about that. I was also having unstable internet. Okay, so we have weak or moribund coordination of case management core groups, especially at the state level and LGA level. So these coordination platforms are very important, to make sure that quality is maintained, in the management of malaria across board, because we all know that, these cases are mainly, in the hospitals, and some of those hospitals are also majorly within the state, located in the state, and of course the PHC. So it's important that coordination framework is, put in place and flowing appropriately in those areas, the state level and the LGA level, like I said, for quality improvement. And also for some of the secondary health facilities, clinical meetings are not, are also lacking, medical, those of us in the medical profession would attest to the fact that, continuous clinical meetings are, forums where issues on clinical matters are deliberated on, to ensure quality improvement, and also quality in management of cases. So supervision and monitoring. So there's also weak supervision at state level, ranging from the team composition and also the frequency of monitoring of these health facilities, starting from both in the state, the secondary health facilities, and of course the PHCs, within located in the states. So we also have inadequate documentation and surveillance. So in terms of data, it's not properly monitored and flowing, as it's supposed to be. So call to action. So call to action. So it's important that we, this, like I said, this is an area that we're really focusing on. It's important that we try to meet up to our vision of the program, which is a malaria-free Nigeria, and to reduce malaria burden to pre-elimination levels, and bring malaria related deaths to zero. So it's important that this is brought to the front burner, and all hands are, on board to see that we're moving down the lane to, meet our vision. So if, like I've said, we have unmet needs, the implications can be very enormous. So it crosses around, it goes through the risk of increased malaria burden. Of course, we have, increase in burden and mortality, and even our gains, what we have so far, in terms of 23% prevalence can, we can lose that further, as in increasing the morbidity and mortality. And also, we can also have the threat of a weakened workforce. We know that most malaria is very prevalent in our country, because of how the epidemiology and topography of the country, so we have malaria very much with us. And so if we're not meeting up our targets, we could have weakened workforce, and decreased productivity. And the consequences, of course, is on development of the country. And also we have loss of confidence in the public health programs and also the public hospitals. A situation where people would say, if we get to the hospitals, we're not being cured of simple malaria. So that's really a big issue. And also to that effect, we're kind of saying that for the clinicians, they need to promote professionalism. It's important that they adhere to the National Malaria Policy guidelines on diagnosis and treatment of malaria. And what that means it's that we should test all suspected cases of fever and then prescribe recommended ACTs. Like the permanent secretary said, monotherapy has been banned for the treatment of malaria. And then place all pregnant women on SP monthly after first trimester of their pregnancy. And then, of course, teach and mentor young professionals to do the same too. Procure and dispense recommended diagnostics, microscopy, RDT, UMT, and then medicines, example, ACT, injectable artesunate should be procured and dispensed appropriately. And then, of course, ensure accurate documentation of national surveillance, that is the data on malaria needs to be accurate, So we need to, next slide, please. We also need to ensure non-malaria fevers are, at the health facility level, we also need to ensure that non-malaria fevers are treated appropriately. So if malaria test is negative, that fever should be further investigated for the cause of the fever. So it goes to say that it's not all fevers that is malaria, caused by malaria. So acquaint all health workers with current guideline and review facility-based malaria case management SOPs. This will help in effective management. Provide access to testing. Like I said, use quality assured, like RDTs, all of them should be quality assured. And then quality directed procurement, good procurement practices too. So make sure that procurement is ongoing, trying to avoid stock out of both the test kits and also the medicines. And then, of course, operate good monitoring and evaluation system. Next slide, please. So at the LGA and state level, so it is for us to ensure availability of healthcare professionals through employment and equitable postings and minimize transfers, so these are issues both at the LGA and state level. So we need to, try to adhere and see that these things are followed through at that level. Ensure regular procurement and uninterrupted supplies of quality assured malaria medicines and commodities. Provision of equipment and facilities for supportive care, example, ICU facilities, ambulances, for the health facilities. It's important that the states and also at the LGA level, we have all the equipment that we need in the management, at least the major equipment we need in management. And of course, resuscitate and strengthen coordination platforms at state level and facility, LGA and facility level, improve and operate good supervision, monitoring, and evaluation system. Data is important. That's what gives us the statistics, and it helps us to also further plan for the country. Next, please. Next slide. Next slide, please. So for us as individuals, what should we do? So we must continue to insist, if we're down with fever, please go back. If we're down with fever, we must demand that that fever must be tested. And if we're positive, take quality assured ACT. That's our responsibility as individuals. And if we're negative, don't take ACT. Even when your healthcare professional gives you ACT, tell him, no, your test came out negative. Can you further investigate me to know the cause of my fever? So you need to insist, it's your right. Things need to be properly done for you, So practice preventive measures. You and your family should sleep inside insecticide treated nets. If you're pregnant, ensure you take SPA as prescribed by your health provider. Ensure that your children under 5 children get the seasonal malaria chemo prevention if you're in the eligible state. And then of course, ensure that your environment is clean. Next slide, please. So in conclusion, the national guidelines provides direction in implementation and standardization of malaria diagnosis and treatment in the public and private sectors in Nigeria. And it's important that we bridge the gap between policy and practice. So what we speak in policy needs to, be effected in our practice. For us to achieve a malaria-free Nigeria, I need to play my part and you need to play your part. Next slide, please. So while thanking you, it's important to note that NMEP Electronic Toolkit houses very useful strategic documents on malaria case management. So you may want to visit today, on our website, which is www.nmcp.gov.ng. Thank you very much for listening.
Thank you very, very much, ladies and gentlemen. That was Dr. Nena Wulafor, representing the National Coordinator of the Malaria Elimination Program. Please give her a virtual round of applause. That was very, very well delivered. I only hope that this edition will be made available to all institutions that are training members of the health team. I have learned a lot from this presentation, and there's a barrage of questions for Dr. Wulafor from members attending this. She's not going to be on the panel session, so perhaps we should just direct a few of the questions to her now. Dr. Wulafor, I hope you don't mind. There are some questions from the floor. The first is that syrups are not recommended for the management of uncomplicated malaria in children. Why is this so? And what is the difference between syrups and dispersibles with regards to efficacy? If you could please take those two questions, we would appreciate. They're from Inimuvie Ekada, who is attending this event. Dr. Wulafor, please oblige us with the answers to those questions.
Hello, can you hear me?
You have the floor.
Okay, so sorry, I couldn't hear most of what you were saying. I know you talked about availability of this edition.
Yes.
Of the guideline. Yes.
Training.
So we're yet to because of inadequate funding, we're yet to still print a whole lot of this edition of the guideline. But just like I said in the last slide, the guidelines are already up there in our website. So if we can go to our website, we can also download it. But we're making effort to see that we, have it printed so that we can also distribute. So I know I had the question on the why syrup, why not syrup for anti-malarials? Yes. So part of the reasons why we don't encourage syrup for treatment of malaria is actually on the inappropriate use, by the caregivers, So that some of these syrups are supposed to be under a particular temperature, and so, the issues around electricity when it comes to, Nigeria as a country, and also the issues around knowledge or education, so to say. So most caregivers, don't get it right. Some of them would, start using this syrup for treatment, for the treatment for their children. And probably when it's not exhausted after that treatment, after the fever, the malaria is, after the malaria has been, after they've been cured, or, after the child has been cured of the malaria, they still keep this syrup. It shouldn't be. So there are a whole lot of issues. So for us in the program, we're kind of advocating that we have disposables, disposables that you can use once, and target it, there and then. So we're kind of discouraging, majorly because of the management around the syrups, that's why the program, because eventually, one is realizing that the children are not, the content, the pharmacological content of these syrups are not, kept as it should be in terms of, therapeutics, so eventually, you might even be giving a child, what is not, as, or as it is, prescribed, by that medicine. So that's the reason why we kind of advocate, the dispersables, which is what you use once and for all. It's better than syrup, majorly. So for the other questions, I didn't exactly get you on the other questions. I don't know if you can take them again.
Yeah, I think you've answered several questions in one. Thank you very much, Madam, for that presentation once again. Thank you.
Thank you.
Inimuwe Ekada, you've heard it. It's about efficacy, it's about bioavailability, and it's about preservation, the difficulty of preserving pharmacological content in syrups as opposed to dispersible tablets. Thank you very much again, ma'am. We will now take a goodwill message from the NLNG, the General Manager, External Relations and Sustainable Development of the NLNG, Mrs. Eyono Fatai Williams, will now give us a goodwill message from the NLNG. Thank you very much, Madam.
I'm trying to unmute. Okay. Okay, well, I'm sure the protocol has been established, so it's just to say thank you very much. Good afternoon, distinguished ladies and gentlemen. It's really an honor to be here and to be asked to give a goodwill message on this very crucial subject that affects all our lives in so many ways, on the diagnosis and treatment of malaria. Recently, as you all know, Nigeria LNG, inspired by our vision to not just to be a global company, but help to build a better Nigeria, we started conversations with relevant stakeholders on making our operational base, Bonny Island, malaria-free, in appreciation of our sustained healthy relationship with the host community. This community has supported our successful business operations in the last 21 years with multiple dividends, and a lot of them have accrued to our nation and our shareholders. I think it's public knowledge that we generate huge benefits to the country. And last week, we supported the federal government in the Decade of Gas conference just to move that conversation forward. But I think the important thing on malaria is that I did mention earlier that we have an interest in malaria, and it's of interest, it should be of interest to health professionals that as part of our Giving Back to Bonny community, on the 23rd of March, we signed a 5-year MOU with the US Agency for International Development to make Bonny Island our operational base malaria-free. The MOU was signed by AD Managing Director, Engineer Tony Atta, with the United States Ambassador, Mary Beth Leonard. Through this program, the US President's Malaria Initiative, the PMI, USAID will provide technical assistance to NLNG's Bonny Island Malaria Elimination Project. The elimination project seeks to reduce the malaria burden, move the community to pre-elimination status, bringing malaria-related mortality to zero. That's really a target. And also to make Bonny Island our country's first malaria-free zone. The PMI is focused on reducing malaria-related mortality, I'm sure most of you know, by 50% across 24 high-burden developing countries in sub-Saharan Africa, and that includes Nigeria, and 3 Southeast Asian countries, through a rapid scale-up of 4 proven and highly effective prevention and treatment measures. The MOU also includes a partnership between us and the US CDC through the President's Emergency Plan for AIDS relief to support us in our control of HIV on Bonny Island. Some people will know that the control of HIV is something that Nigeria LNG has been involved in since the inception of the project on the island. I think for us, this is really part of our plan to ensure that Bonny becomes, it is a plan, a major tourism destination of choice in Nigeria, riding on the rich history of Bonny, the rich culture it has, and the strategic geographical location. So ladies and gentlemen, it's of note that I find this conference quite apt, and I look forward to the interesting discussions. I'm happy that our own Chief Medical Director is also going to be on the panel, Dr. Kunz, and I know he will do justice to whatever topic he's been given. But we look forward to the outcome of this, also enhancing our program to ensure that we join Nigeria in this fight against malaria, starting with Bonny Island as a pilot, and hopefully the rest of Nigeria can learn from that. Thank you very much for your attention, and please have fruitful deliberations for the rest of the day. Thank you. Back to you, Doctor.
Thank you very much, Mrs. Fatai Williams. We can always count on the NLNG to lead the way in the public-private mix. I just love that company. I really love it. It's done so much good in so many ways. And it also pays a lot of tax. Thank you very much, madam. I saw Senator Olorebe on the platform. I don't know if he has arrived or he's still, I was still awaiting his arrival. We were to take his goodwill remarks earlier on. Is Senator Ibrahim Yahaya Olorebe with us, the chairman of the Senate Committee on Health, distinguished Senator Olorebe. Well, we will now take the submission of Professor Wellington Oyibo, who's a professor of Medicare Microbiology and director of the ANDI Center of Excellence for Malaria. Is he with us? Professor? Okay, we may then have to go straight into the panel session. The moderator for the panel session is Dr. Neka Onwu, the director of the Department of Community Health Services of the MPHCDA. And she has quite a team of panelists who she will be introducing when she takes over the microphone. Amongst them are Dr. Abdul Wahab, Dr. Rabo, who may not be present, Dr. Ohio Moswan, Ohio Simwan, Dr. Fajola, Dr. Shinawa, and Malam Yusuf Mohammed. So, ladies and gentlemen, I have the pleasure of passing on the baton to the moderator of the panel session, Director, Department of Community Health Services, MPHCDA, Dr. Nneka Onwu. Madam, welcome. You have the floor.
Thank you. Good afternoon, able anchor. And then also to recognize that we have established protocols. So permit me to stand on those protocols. I did realize actually that Senator Dr. Ibrahim, and I don't know whether the NGF also governor, the DG for NGF, whether he's also for that goodwill message. If not, we'll just go ahead with the panel discussion. And indeed, today has been a very interesting day for me. Of control. We are also aware of all the guidelines and declarations that have been made in the past in 2000 that set the tone for what we are doing today. And from the earlier presentation, we did hear about the reviews of the guidelines, national guidelines for us, and today is the 4th edition. So indeed, it's a pleasure for me to welcome very distinguished panelists who will be doing justice to this. Of course, they don't have all the knowledge, but at least we know that they'll give us a good run for our money. And of course, talking about money, the effect of malaria on the economy of this country is something that we all know. And our data, especially the National Health Act and other surveys we've done, lends credence to this. It is a peri-COVID period. And the chair of NESH did talk about the cases, increasing cases of malaria, the morbidity and mortality that has increased over the last 1 year or so, recognizing that even in 2019, we did have a drop from 27% to 23%. So what do we have today? Our panelists, it'll be a pleasure to introduce them if it is okay. I would like to welcome one of our panelists, Dr. Julie Irabo, Executive Secretary, Edo State Primary Healthcare Board. Julie, we welcome you. In the presentation, we did hear a lot about what we need to do at the implementation level, the state, the LGA. So I think it's apt that we have you on board as a panelist to be making good on our words behind our actions in terms of what we need to do around malaria in the country. We'd also like to welcome Dr. Ahmad Abdul Wahab, a senior health advisor of the Nigerian Governors Forum. We remember also that they were part of the last edition in 2020 when we launched this edition. So we welcome Ahmad and we thank you for being in this panel. And we know, and I do know you, that we'll have a lot to discuss when you start your presentation. I also have Honorable Dr. Richard Kofi, Chairman, Oyele South Local Government. Where would we be without our chairman in the LGA? Those who are responsible for that level of implementation that is responsible for our vulnerable population. We welcome you, Chairman, and I know you will also bring yours to the table as we go forward in our discussions. Dr. Abimbola Oshinowo, Deputy Director, Lagos State Malaria Elimination Program. Lagos is the champion state and you continue to lead. So it's no surprise that you are in this panel. We'll also be anticipating what we'll be talking about. Mr. Emeka Nwachukwu, DG Marketing, Jeanette Pharmaceuticals. A lot of talk about ACTs, about marketing, what we need to do about our test kits, the RDT, the UMT as well. So yours on that will be very interesting to listen to. May I also welcome Dr. Okuns, already introduced by the earlier goodwill message from LNG, that he'll be telling us about public-private sector partnership. Yes, where we have very fiscal space is really, dwindling. What is the private sector? What is your role? What is your take in this? Malaria is killing us. Its cost to the economy is high. Let's hear about it from the private sector. So if it's okay with everyone, having introduced and called all of them, would like them also to show up on the screen. And let's start the discussion around this 4th edition of the guideline. Dr. Obulafor took us through the background in terms of our figures. Now, can I welcome Dr. Julie Irabo around? Okay, Dr. Ahmad, you're on call. So you were here the last edition. So we are welcoming you, and we want to hear your take on the presentation, as well as malaria as a burden in the country. What are we doing? The governors are the chief executives of our states. We've heard about the states, we've heard about the platforms, coordinating platforms. We've heard about resources, strategic plan for 2021 to 2050, 1.9 trillion, wow. So let's hear you on this that has been presented earlier. Dr. Ahmad, welcome.
Okay, thank you, Dr. Onwu. And first, let me start by expressing the apologies of the DG Nigerian Governors Forum, who was actually supposed to give a goodwill message. He was on, but he had to leave. And he asked me to actually extend his apologies, and then to also assure the forum that the NGF is really very interested in what is happening on malaria. Malaria is really a very important disease. And just like you mentioned, Dr. Onwu, that NGF partnered with NESH to actually organize the roundtable last year. And we're also very happy to actually partner with NESH again in this dissemination of the guideline of malaria. As one of the challenges that was mentioned in the course of presentation by the NMEP was the non-use of the guideline. And so I think having this workshop, having this seminar, webinar is really very important. It's an important step towards disseminating the guideline. And we want to assure NESH and everybody here that NGF will continue to partner with every interested party to actually see that we not only disseminate this guideline, but actually make sure that we strengthen our malaria program at the subnational level. So once again, apologies of the DG. And so coming to the discussion of this presentation, I think this presentation was really very interesting. And for me, the key take home in terms of the emphasis of the National Malaria Program on the key strategy of testing, treating, and then tracking. I know some years back when I was in Ethiopia, that was a long time ago, and then I traveled to Ethiopia, and then I was having symptoms of malaria, and I was asking for anti-malaria. They said, no, they have to test me first. They don't just give anti-malaria, they have to test first. And that was several years ago. So I think it is really welcoming to see that there's so much emphasis on this now by the NMEP, and that we'll try as much as possible to actually encourage people to test before they treat, so that the irrational use of anti-malarials is going to be reduced considerably. And then it's also heartwarming to hear the issue of the urine malaria test. I think the less invasive a test, the more it is going to be popular for use by the general public. So I think we need to popularize the use of this urine malaria test, so that we'll have more and more people getting encouraged, so that you don't have to break your fingers to actually get the RDT done. So listening to at least all the drugs not to use, and then the pre-treatment, the prevention, and all those. But I think for me, the key thing for the Nigerian Governors Forum, for those of you that might not know the Nigerian Governors Forum, is a platform of the 36 governors of Nigeria. And the purpose of that forum is actually to promote good governance, and also try to see peer learning. They also promote peer learning among themselves. And then if there are things that are of common interest at national level, subnational level, they try to push. And health is one of the priorities of the Nigerian Governors Forum, and especially trying to promote universal health coverage. And in this climate, you can't talk of universal health coverage without talking about malaria in this slide. And what the Nigerian Governors Forum is doing is, we know we have this challenge of fiscal space. Now, the program mentioned the trillions of naira that they're expecting to be able to effectively fund the strategy, that the plans that have been produced. So, and we know that there is this constraint, and with also the challenge of COVID. But what the forum is doing is looking at innovative ways of actually generating more funds that can actually be diverted for health. And one key intervention that the NGF is promoting is what we call a tax for service intervention, the tax for service. This tax for service is an innovation that we want to use that want to encourage people to pay their tax, but as they pay the tax, there should be something benefit. There's something that they're going to benefit from paying their tax. And so if you pay your tax, there's going to be a minimum set of basic health care that you will enjoy for paying your tax. You don't have to pay for that again. So we're exploring that. We've not finalized it, but it's one way that we want to improve funding for the health sector. And what happened is from the increased IGR that is being generated, a significant portion is going to be dedicated to health. And malaria, of course, is going to be a key beneficiary to this. So that is one intervention that we are looking to see that we improve the local resources at the various state level. Of course, again, one key priority of the Nigerian Governors Forum is the issue of trying to work with to strengthen the primary healthcare under one roof policy. And I'm happy you have people from the state and then some from the local government. So without me dabbling into what they're doing, but suffice it to say that the Nigerian Governors Forum is actually catalyzing the implementation of the primary healthcare under one roof policy at the state level. And of course, again, one area in terms of health financing that we're also working on is the issue of the state health insurance. So as of now, you'll see now that we have almost 34 states now have signed their laws of establishing a state health insurance scheme, out of which 23 have actually started enrollment. And if we get all this functional in all the states, then the issue of paying for services at the point of access will be eliminated. So people will be able to actually access care when they actually need it. And so, as I said, malaria is going to be a key beneficiary for this. So these are some of the things that is happening at the Secretariat of the Nigerian Governors Forum. And we will really commend NESH for its continued interest in trying to advance all these positive interventions that government is doing, partnering with government to ensure that we get all, especially this dissemination that we're doing. And for us, we'll continue to partner with NESH and ensure that the outcome of this meeting, whatever we've been able to deliberate, some of the call to actions that they've mentioned, we'll be able to actually see that we work with them and follow them through. Maybe I will stop at this point. I will be happy to talk later, and then I think I'll give it back to Dr. Ono. If there are questions, I'm ready to answer, and then maybe later on I can still chip in on one or two things. Thank you.
Thank you very much, Dr. Abu-Hab, and thank you for that and for taking the goodwill message on behalf of the DG of the Nigerian Governors Forum. Yours really around the testing, especially your experience in other African countries and what we see in Nigeria in terms of guidelines, SOPs we have and how we adhere to them. You also alluded to the UMT really being at the LG and community level, of course, it's less invasive and then anybody can use it. And you find that our people want to be pricked to feel pain, to feel that something is useful, but they have something that is so easy. And therefore you talked about promoting it as the best option really in terms of easy to use, in addition to, of course, all the other test kits that are available. So thank you for that. Of course, you talked about domestic funding and the role of NGF in ensuring that things move forward, especially in terms of funding for primary healthcare and the support of a PAC under one roof. We thank you, and we thank you also for saying you'll be available for questions, which we expect to follow. A lot of questions are buzzing. We'll take them right after the presentations. But I would like to also introduce another person who will be presenting, and he's also designated to speak at this time. I don't know if it's okay with the chair and others for me to invite another speaker, Dr. Wellington, if we can call him to make his presentation. Professor Wellington Oyibo is Director, WHO Andy Center of Excellence for Malaria Diagnosis and Professor of Medical Microbiology and Parasitology, College of Medicine, UNILAG. I have been asked to invite you to speak during this session. If it's okay with you, we would like to also hear you if you have any presentation to us before we go further in. After you will also take Professor Mokolo, who will also be making a short presentation. I know time is of essence, but this is a very interesting topic. And we really have to, dig deep. So is it okay, Professor Wellington, to invite you to speak at this time?
Yes, thank you very much for the invites, esteemed moderator. Thank you. Am I on now?
Yes, you are.
Okay, thank you very much. And to congratulate NESH, and of course the Malaria Elimination Program and the partners for this opportunity of speaking to the 2020 malaria diagnosis and treatment guidelines. And to reiterate at this point in the country's current position, control, and what is required from everyone in the implementation of the guidelines. The guideline is for every one of us. It's for the health care providers. And what the guideline has done is to provide that streamlined and guided process, which the healthcare providers will follow to achieve the expected results from the program, and how all of these will converge in the attainments of the well-established goals for malaria in the country. So we're still at the control phase in the control of malaria in the country. The area I'm just going to speak to in bringing up some issues which were relevant in the pursuit of effective malaria case management. One is to see that changing the epidemiology that we have had from the previous speakers. It's already established from the population surveys, the decrease we have seen from 2010, 42%, and to 2015, 27%, and then to 2018 in the NDHS, 23%. But while these ones are going on in population, there's the dynamics of malaria clinically is still heterogeneous across the country, and data, of course, is required at each areas in the in the country, the different ecological zones, different zones and states, as to how the dynamic is working. But I can speak from from data that in some parts of the country, especially in southern part of the country, and places like Lagos, southeastern part of the country, Imo State, Abia State, in South, in River State, for instance, likely in a couple of health facilities, you're likely going to have quite a lot of negative malaria tests. And that's the area I really want to put our focus on. How do we handle the challenges of a negative malaria tests in facilities when the symptoms are showing clearly that, it's likely that the patients will have malaria? It's a little bit of confusion because everybody seems to approximate all fevers to be malaria fevers, and it's not true. And that's a great deal of a challenge we have to deconstruct, especially among the healthcare workers. When this happens, the burden is put squarely on the capacity of the tests to do the diagnosis. So if we have in mind that in places where we're working, if you have a negative test, how do you handle it? And how should we navigate that process in ensuring that the patient is properly managed? So the knowledge, the understanding to a large extent from local data, from facility experience as much as possible is important, which means that data review in facilities must be done regularly. You want to see how much of tests done in a month are positive for malaria. You have your the proportion. And then this one goes into how the facility is preparing to handle some of the changes that are seen. And why undertaking that, which meant to that data concerning malaria diagnosis must be kept. It means too that the quality of diagnosis must be high. It means too that the recommended tools must be available and properly stored, whether it is a UMT or the rapid diagnostic test or the platform for malaria microscopy. All of these will have different requirements of capacity that should be put in place in terms of utility and how they can be properly used. Now, for the RDTs, I want to use this opportunity to say that the rapid diagnostic test has its very good place in malaria case management. And this rapid test, of course, it includes the blood-based RDTs and it includes the urine-based RDTs, having gone through rigorous clinical trials, have their place. And of course, the value around this is that in most cases, and I'm saying it with some level of confidence, in most cases, for the blood-based RDTs, for over 92, 93, 95% of the cases, these recommended RDTs by the National Malaria Program, HRO2-based RDTs, will give you a very satisfactory results. But the contention has always been that how do you match these results that are likely negative, with the presentation from the patients? It is worthy to note that, of course, the etiology of fever is many, and must still be malaria. You ask yourself, a patient presenting with fever or symptoms of malaria, for instance, must that person be be treated for malaria? So you've seen the very high presumptive, use of ACTs, that which we have published around as well. So the need for testing is critical. The management of a negative test has to really begin to, incorporate the other areas of quality that, should be established, and of course, the other pathways to go. While malaria microscopy will still be problematic in terms of the capacity that is required, to actually either perform that process and to finally read it, the RDTs have, to a large extent, been very important in the provision of access to malaria testing in the country. In 2019, of all the tests that was done, about 85, 86% of those tests was by malaria rapid diagnostic tests. That does not minimize malaria microscopy at all. But in this meeting, for all our participants and all who are listening, we want to emphasize that the malaria rapid diagnostic tests recommended by the program that are procured, especially to the public sectors, are very high performing. I'm speaking to the confidence of the tests. And it means too that if you put all of these alongside the epidemiology of malaria in those settings, you begin to agree with me that the tests are performing. There are things the healthcare provider should have some confidence on. And if you're not having that confidence, then you want to demonstrate how your opinion is changing from what is established. And to do that, it means that a quality system, really has to be established. That has to be in place. And if you have a healthcare provider that is having a different opinion, then you need to ask what basis or what capacity that healthcare provider has to make that kind of assessments on the RDTs. One thing I will bring forward here, that in some cases, the malaria rapid diagnostic tests are not being used. They're not being used because of either the orientation of the healthcare provider, which has put them in a biased situation that the RDTs are not performing. That is not correct. For the data we have before us, we have actually tried to pull up something to show here. We got about 100 tests done on patients in this between mid-March and April ending. 100 tests. Out of those tests, I pulled up the data. Let us see the number of malaria rapid diagnostic tests that were negative that eventually became positive by very high level microscopy. Of these 100, there were just 2 cases of malaria rapid diagnostic tests that were negative and was positive, by top level microscopy. So that gives us almost about 98%, sensitivity, specificity rather, negative by RDT. Only 2 of those. And when we look at the data, those data for the 2 positive cases by malaria microscopy, we found out that the parasitemia was really very low. So if you have a test that can do well, negates malaria, with a negative test in 98% of the cases, then that test is good. I brought this analogy to just let us know that when we see negative malaria rapid diagnostic tests, I think the next point is to begin to explore other causes of fever and how that patients can be properly managed. And that's critical for us. So I'm not talking about sensitivity now, but when the test is positive, of course, the healthcare provider knows what to do. But again, to bring up the fact that you could have comorbidities in managing that patient with fever or the malaria-like symptoms. Where you have comorbidity and then you're just choosing one, it's likely to that the other morbidity will still be there and still make patients unwell. So my final point here is to emphasize, 1, the high-performing natures of the RLDTs, and number 2, microscopy could give results based on the user. So capacity building is important. The creation of a platform for quality is important, and all of this should be in place. So whether it's a blood-based RLDT or a urine malaria diagnostic test, we have data that shows that they are stable at quite a number of the temperatures in our facilities, but yet they have to be stored properly and all quality control measures established. So that's the strong point I wanted to make in this meeting. I want to congratulate NESH again, and then of course the organizers, and of course our dear Malaria Elimination Program. Thank you very much.
Thank you very much, Prof. Wellington. And you really started with taking us through epidemiology, looking at where we were in 2010 and where we found ourselves in 2018. One wonders what happened between that 2010 and 2018. You also talked about data and importance of data in terms of malaria control. And then the what, I'm from that region. And when you tell somebody the person has malaria negative and says not malaria, how do you deal with it? And you talked about the issue of human resource and the capacity of these workers. So how do we deal with it? When my people come and say they have malaria and you tell them they are negative, so how does a health worker deal with that? Of course, in this same area, we have our patent stores, and we know that's the next port of call. Issues around human resource for health, and even these labs that will give you, for those tests. And you talked about RDT, emphasizing, the RDTs and UMTs, where they are used and how important it is to us. So we appreciate you for that. And I think you should stay around more for more questions that will be coming around your presentation, especially around the lab. Microscopy, what it means. There are questions around, are people saying is typhoid? There's a proliferation of typhoid fever. I have malaria and typhoid. I'm sure those questions will come to you when we get to the Q&A, but we need to move on because of time. And it's my pleasure again to welcome a distinguished gentleman, a very senior colleague. Professor Mukolu will also be talking to us, and Prof would like to hear you and malaria and the issues we have been discussing to national guideline. and malaria control in Nigeria. We welcome you, sir. Thank you.
Yeah, thank you very much. I'm quite aware of time. Please, I'd like to share my screen in order to facilitate this presentation. So if I can be given permission to share my screen, I'll keep it short. All right, thank you very much. I'm going to come at a slightly different angle because again, this is hosted by the National Entrepreneurship Summit and Honors. We had also considered putting something on the menu for an entrepreneurship-oriented audience in part. So I'll be talking very briefly about entrepreneurship of malaria elimination in Nigeria. I will not want to bore us anymore with all the details about trends and morbidity, mortality figures. But all I just need to highlight here is that over time, there has been some important successes with about 1.5 billion malaria cases averted since year 2000 up to 2019, and about 7 million malaria deaths averted over the same period of time. So we've made some progress. The contribution of Nigeria to morbidity and mortality is already known, and this has been the trend over time. Our anchor has asked a question, what happened between 2010 and 2018? Sorry. Between 2010 and 2018, just to say that by 2015, the prevalence was 27%, and then by 2018, it came down to 23%. So we'll be making that progress over time. Okay, but I will go on now into more of the economic toll of malaria very quickly. And just to say that from accounts from the CDC, the overall expenditure on malaria in terms of direct costs for procurement of treatment is about $12 billion per year overall. But when we look at several other types of indirect costs, then it becomes very high. And that is why at some point it was said that everybody pays some form of malaria tax. We had also undertaken a study to directly study the effect of malaria on farming efficiency and productivity. And we studied a particular community. We were able to follow them up through the farming season. The highlight of what I just want to show you is that we're able to classify the households into those who had high malaria during that session and low malaria. These were defined by us. Okay, but the summary of the finding is that if you look at all the blue columns, they represented households with low malaria, and their farming productivity defined by kilogram per hectare of the product was generally higher across board, except for sorghum, which planting season was not quite as time sensitive as some of the other shorter term products that we have there. So we see that malaria actually exacts some important economic toll. One, in terms of direct cost, two, in terms of productivity in the area of agriculture, and three, we also see that in terms of health expenditure, from the national health account, 76.6% of health expenditure is out of pocket, and about 44% of that is spent on malaria. Okay, so that's the kind of economic tool. So making a business case for the journey towards elimination, these are the various interventions that we use in terms of vector control, chemo prevention, the diagnostics. So we've been talking a lot about the diagnostics today. because of our reference to the guideline, as well as the drugs that are involved. But looking at the entire malaria landscape, we have commodities that are produced for vector control, and then drugs for chemo prevention, as well as other activities like surveillance and communication, where we deploy technology and the media outfits. From the latest National Malaria Strategic Plan, the Strategic Plan 2021 to 2025 is estimated to cost nearly $5 billion. And the implication of that is we have a space of about $1 billion annually. So when we are talking about malaria entrepreneurship, we are dealing with $1 billion industry in actual fact. And when we resource for malaria, ordinarily we look at government, we look at external funders, we also look at the private sector in meeting our needs. But we can look at the private sector a little bit further, and we can see that the private sector, we can identify resourcing malaria either from philanthropic activity, public-private partnership, and then entrepreneurship. This entrepreneurship can be social entrepreneurship. What NESH is doing, for instance, is a form of social entrepreneurship. They are creating a great platform to bring important opinion holders and various stakeholders in order to be able to achieve an objective of adherence to treatment and treatment guidelines. That's a form of social entrepreneurship. But there are innovations where there can be investment. You have just been told about the urine malaria test, for instance. It's an innovation to add another layer to blood-based RDTs. We can have assisted microscopy. We still have vector control. So we are saying that for the entrepreneurial-minded person, there are opportunities. And then there are entrepreneurship. Each time, for instance, there is a campaign for nets that goes on. When you look at the budget and the infusion of resources into a particular state, if we're able to do those analyses critically, it supports the economy of the state and injects new funding into those states. So we need to begin to see the business dimension of malaria as well. But specifically, permit me to present also to us the model of backward integration. I don't have all the time to explain, but basically it's a business model whereby a company takes direct control of its products as they are supplied. And in this case, when you look at malaria, we're looking at the commodities that are needed. And we're saying that the entrepreneurs, the manufacturers, pharmaceutical companies can have an arrangement with government to have a protected market, whereby government is assured of quality products and the manufacturers are assured of a market. And we create a win-win situation of access to genuine and affordable drugs, okay, which complements whatever other partners are doing, that is allowing for free drugs to the very poor and very vulnerable, but to those who can afford, that is also cheap and affordable products, but that are genuine. And if we look at this model of backward integration and we raise this conversation and have an organized sector that is able to ensure that production is made according to global standards, we'll be having a mechanism of sustaining the continuous supply of malaria products. So this model, we are presenting it such that government can provide oversight and leadership, whereas all the other players will be involved through some incentive arrangement in order to make commodities available in a continuous sense. And that will contribute to sustainability in the long run. So we have a conceptual framework for this model developed by me. So you can see how to plan for the need, how to source, and identify the suppliers, how to manufacture and produce the items that are needed, and then how to deliver and how to have some return on investment. So this is really the conceptual framework that is being presented, that in addition to direct contributions for malaria resourcing, we can actually create an enterprise whereby there are now, it's as if we are doing crowdfunding, and there are multiple sources of investment in that malaria space, and there are resources that are being used to facilitate distribution and access to products. So in my own brief remark and conclusion, I want to say that malaria entrepreneurship is an approach that will contribute in a sustainable manner to the quest for malaria elimination. The business case shows that malaria elimination is a multi-billion dollar investment, not just multi-billion dollar investment opportunity. There is a host of opportunities for entrepreneurship with various innovations, whether social, whether innovative products and the like. Backward integration as a concept will allow enhanced sustainability of malaria control program as the supply chain, including production, distribution, logistics, and design, will be under the control of the government in partnership with the private sector. And then this will allow for consumers to have access to quality products at very affordable prices. I would like to leave this particular statement with us for us to chew. Malaria is bad for any business, but the business of malaria is good for everyone. I want to thank you for allowing me to make this input into this seminar. I thank the organizers and the National Malaria Control Program. Thank you very much.
Indeed, Prof, is a good one to chew. Malaria business is good business. Who wouldn't want to be in $1 million investment business like this? And of course, you highlighted on the importance of NESH in terms of entrepreneurship and also intrapreneurship. And you talked a lot about good things in terms of innovation and technologies, how bring it to bear. And we look at economics, and when people look at health, when they see it now, they see the numbers and see what it costs. So thank you very much, Prof, for your presentation. A lot of people looking forward to getting, I'm one who'll be looking for that presentation. Thank you so much, Prof. And I think that the time is of essence, and I don't know how we're going to cut it, but I think we're going to take some of the panelists also bring up discussions, but we'd like to, streamline it so that we can take our questions as well. So Prof, we thank you. We'd like to invite other panelists on board. And it will be my pleasure to invite the next panelist. And I think I'm looking at Lagos State, if I'm okay, just to bring on, to highlight the next panelist who will be taking us through their thoughts around what has been presented today. Just a minute. It is my pleasure to welcome, I don't know whether Honorable Dr. Richard Kofi, if he's around, I would like to take him to, he's the chairman of Uyeli South Local Government. And we talked about the LGAs. Now we've talked about $1 million questions. We talked about what effects we have in terms of what we do in our communities. I don't know whether we have Honorable Kofi, Richard Kofi, the chairman of Uyeli South Local Government, to, as one of the panelists, to also take us through his thoughts around our presentation, around the national guidelines and how we've been controlling malaria. Of course, discussion around technologies and then other things that we brought to bear, financing, coordination at that level. And in addition, is the community structure. How do we use the community structure in tackling malaria? I don't know what the honorable is around. If he's not around, please kindly highlight the next person, which will be Dr. Abimbola Oshinowo, Deputy Director, Lagos State Malaria Elimination Program. Lagos State leads, others will follow. That is my state. And if she's around, we'd like her to also give us her thoughts around this, the discussions today. Do we have Dr. Oshinowo?
Yes.
Okay. Okay, my sister would like to invite you. to please talk with us. What is happening in your state? We've had a presentation around responsibility of the state implementation level. Let's discuss Lagos State and the National Malaria Elimination Program. You're welcome.
Thank you very much. Unfortunately, I'm still trying to get a grasp of my video and I can't turn on. But let me speak basic, and let me just speak. Let me speak basically on what we are doing in Lagos. First of all, I want to thank all the presenters for their presentation. They have actually paved the way for me to speak. Regarding the presentation on malaria, on the guidelines, I want to appreciate the national program for what is going on in the state and in the country as a whole. And then the states definitely are going to adapt the guidelines based on what is available, so to speak. For instance, urine malaria test, one thing we like about it is the fact that it is non-invasive. Unlike when compared with the blood, it's what is available. The person brings out the urine and then it is tested. What that means is that a lot more people will most likely embrace it, knowing very well that they don't need to be pricked before finding out what they have when they present in our facilities with fever. However, in terms of implementation in the states, we would actually need guidance from the national program. Why do I say so? This is a new product coming in. We would need trainings. Our health facilities would actually require, the personnel would actually require training regarding it. They would also need to know where exactly to put in the data obtained, because data not recorded, that means the activity hasn't been done. So those are some of the things that we would also have to consider regarding hello, can you hear me?
Yes, you have 3 more minutes or less. Yes.
Okay. So I've spoken about routine activities in terms of distribution of LLINs and intermittent preventive therapy for pregnant women. Likewise, our MRDTs microscopy. And now that we have the UMT, we need to incorporate it into what it is we're doing at our facilities. What that means is that we need directives from the federal. Why do I say so? Like I mentioned earlier, our personnel needs to be trained because there has to be guidelines on how this test is done. And then even when we get the result, we actually do need where we will put in that information in our dashboard. Why? Because any activity not documented hasn't been done. And then we're able to compare what the results and what the results are in the states. I mentioned also about our malaria vector sentinel site and our parasite sentinel sites. Vector sentinel sites in Badagry, Ojo, and Ikorodu, and it has shown us across board that there's a lot. The malaria in Lagos State is actually heterogeneous, as mentioned by Professor Wellington, and not homogeneous generally. So in some facilities, in some local governments, will have very high numbers, high prevalence, like in Badagry, Ikorodu, Ojo, they're actually between 4 and 6%, while in a place like Surulere, Oshodi, Isolo, it's 0%.
So definitely the interventions are targeted based on what it is that is available, the information that we have. So as a state, we are more than happy to work to use the UMT, provided guidelines are available from the national and for training and for data input. So we know what is really going on with the UMT. So the presentations have actually been quite enlightening in terms of information gathering. And it's also helping us keep abreast with what it is that we need to know at the moment. So thank you so much for inviting me.
Thank you, Dr. Abimbola, and yours is really well taken. Thank you so much. And using data for action and the need for capacity building, and this follows through from all the presentations. We have issues of time. One is not surprised because time is a problem here when you're discussing such an interesting topic. So it would be nice to invite Emeka and Nwachukwu now, and having spoken about backward integration, $1 million business, I think it is proper that I invite you to speak at this moment. We've also talked about UMT availability and how we use it at that level. Emeka, if you're available, let's highlight him so that he can take us through just a few minutes on what he has for us around our discussion today.
Okay, so like you already said, I want to start on existing protocols. My name is Emeka, I'm a pharmacist. And I'll just talk on two things, basically. We all know how important this issue is, eliminating malaria. I mean, we wish it would have been eliminated by now. But my concern is the kind of attention we used to get about it, the attention we got about it in the past few years, in the presence of what is happening. There's a bigger issue, the COVID issue. Are we still going to pay that kind of attention at all levels? I mean, globally, we know that it's not going to be the same again. The biggest of this world, we have to find, they've found other ways of helping the public, in quotes. So in all this, I also want us to look inwards. How do we sustain this momentum? We have to look inwards. I mean, it's no longer a matter of waiting for the global collaborators. I'm saying that we need to have backup plans, because moving forward, it's not going to be business as usual. The pandemic has taught us a whole lot of lessons, and we must also make sure that we don't keep our eyes away from the ball. You know, the major issue we want to achieve. Gradually, people are no longer paying attention to malaria and then all the issues around it. That's one. The other thing I want to talk about is we seem to be shying away from one fact that has been made very obvious, right from the professor's presentation and all that, the issue of negative results, in quotes. And I mean, and the business angle of it. Some of my colleagues get to see these patients and get to sell the products to them. We also produce anti-malaria. In fact, one of our brands, Camosunate, is everywhere. But now, when they come, the idea, even before they go for the test, the belief of the patient, the person that's going for it, that he has malaria. And so if you give him a so-called result that is not in consonant with what he thinks, he probably thinks you're not doing anything. And trust me, this is business. Some people out there, whether it's the lab or the pharmacies or whatever patent medicines, will be ready to provide what the patient needs. And it makes you a bad professional. It makes you somebody that you don't know what you're doing. I mean, you don't have that kind of confidence. So next time it's not going to come to you. He goes to where he gets what, because by circumstance, by a combination of factors that might not be real, the fever probably gets to disappear after he takes the medication. Okay, and so you put it in proper perspective. This guy says I don't have malaria. Well, I know I have malaria because this other person said I have malaria. He validated the test I had earlier, and he gave me drugs, and I got better. And he flows with that. He believes that. So I think we need to do more in terms of enlightenment, in terms of letting the people across the whole chain, from the patient to the healthcare providers and all that. And then, because I know that the people on the business end of it will want to protect their business. Even the doctors, I know of some doctors that I don't want to, well, it might be, but I know that some doctors might be forced. You know, when a patient sits in front of you and he tells you I have malaria, it's not even started. The first thing he says, I have malaria. I mean, you begin to wonder, how do you navigate around that problem? So these are the two key issues I don't want us to lose sight of. The fact that we need to start thinking inwards, the fact that the global interest in what we are doing, what we hope to achieve can never be as it used to be post-COVID, as if there's ever going to be post-COVID. And then this issue we're all trying to run away, trying to pepper it, Prof has talked about it, asking rhetorical questions, is real, okay? How do we deal with the fact that as a healthcare professional, if you want to go follow it strictly according to the way it should be, you probably might be losing out in some things. For now, this is just one or two of my brief comments.
Thank you very much. So what do we do? Negative malaria test. And this is business, $1 million question. Where do you go? The pharmacist is producing the drugs. The doctor wants to make money. And then the patient needs to also be guided or, based on what we have and treat based on guidelines. And I see that Perpetua's hand is up. Perpetua, I'll let you be for now. We'll not ask that question. Let's take the next one. We're looking at the private sector, Dr. Okuns from the LNG. We're looking at the private sector as well. We talked about business. We talked about how do we test, even in LNG clinics. So we have the enlightened, the literate and illiterate. Our populations are very, very not that literate. So how do we deal with this? How do we deal with the business angle? And you talked about backup. Our plan should not be backup to the global. The global should be backup to ours. So the business is the private sector. Emeka, the NESH is leading the way in entrepreneurship. What else do we have here in terms of the manufacturers and the business is the private sector? Can we hear Dr. Okuns? If you're here, we'll hear you. We have 5 minutes to hear you.
Thank you. Yeah, I will try and give as much time back as I can. I really appreciate how much time we don't have. So let me just first of all say that the private sector has a lot to do. We've heard about the cost of malaria, but also the cost to be made in malaria, and it works both ways. I was reflecting just yesterday on how much money has been raised by the country attacking HIV,
for now, follow
the COVID pandemic.
Follow the
There's some background talking. I think it's, yeah, thank you. And yet malaria will kill more during the period of the pandemic than the COVID will do. So government has its own responsibility to do its part. Because of the malaria elimination program we are running, we've actually sponsored the AOP for Rivers State for, I think, 2019 and also 2020. But that's really something which I think the government should be doing as part of their commitment to eliminating malaria. Specific to what we are doing, like my GM said, we are committed to making Bonny Island a malaria-free zone. It's interesting, even from the medical community, how many people think this is not possible. And I always refer them to go back and look at how many countries in Africa have eliminated malaria. And I remind people that the CDC, which we know today started as an agency for the elimination of malaria in war zones, because America even had malaria. So if these countries and landlocked countries can eliminate malaria, certainly something we can do as a country. What I would urge people to do is not go and reinvent the wheel. One of the strategies that we have adopted is to simply key into what the NMEP is doing. It's a fantastic thematic-based elimination plan. We've done already quite a lot along those lines. We've looked at our baselines. We've done our baseline studies, looked at prevalence on the island. We've identified the health systems there and looked at the gaps. We are scaling up activities and building capacity all along the thematic areas that you have in the NMEP. We've collaborated already with the CDC. We've run studies on resistance, which has told us that the current nets we have in circulation there are not working. And these are the ways we hope other companies will begin to look at the areas where they work. It's in their own interest to ensure that they reduce the downtime of their workers and also allow the workers spend more of their money on other things apart from treating themselves and their children. Finally, I'll round it up with just some comments on the 4th edition of the national guidelines. I recall I was still in active practice when the first one came. It was a very welcome way we direct the country in treating malaria. One of the things I see very different in the private sector where I've worked, where we do not treat people who are negative for malaria, versus what I saw when I was in government for over a decade and a half, is the consequences for what we call non-standard care. I think this is something the government must be looking at. The health sector must be looking at. When are we going to begin to have consequences for people who simply refuse to follow recommended guidelines deliberately when there's really no excuse for it? Because what I've learned is that without consequences, there really will be no compliance. The other thing I think we should look at as we put a lot of money into malaria diagnosis and treatment is also to be able to show healthcare workers that there are other things that cause a fever. And in truth, if all you can do is say it's not malaria, but you do not have any means of saying, and therefore this is what it is, and this is about concentrating on the ways to make simple viral diagnosis in our community, as happens in many other places, people will still generally default to saying, you know what do I have to lose by just giving some antimalarials? And I think that's another area we must not neglect. Thank you very much, and back to you.
Right, thank you very much. And I'm informed that we really don't have time, but want to appreciate you for that, coming from the private sector and what you're doing and what we need to learn. I think if it's okay with everyone, it's good for us to go to the questions. And I'm happy that Perpetua's hand, that is a National Malaria Elimination Program, that your hands are up. So quite some questions for you. Initial one, the person still says needs more answers. Kelechi Kunwafo, is it okay to go to the questions, Anchor? Do I go ahead with the questions? Please. Okay, so the questions from Kelechi Kunwafo. Why is it wrong to administer anti-malarial syrup for children less than 5 years? Please, is there any chemo prevention for the aforementioned age group? Can I take it again? It goes to National Malaria Elimination Program. Why is it wrong to administer anti-malarial syrup for children less than 5 years? And is there any chemo prevention for the aforementioned age group? Thank you. Welcome.
Okay, all right, thank you. So this is Dr. Perpetual, I'm the national coordinator. Actually, I appreciate Dr. Ogbulafo for making that presentation on my behalf. I'm actually in between 2 meetings right now, but I just didn't want to miss this completely, because I think this is a very important discussion. Now, for the question on the why it's wrong to administer syrup to children, Dr. Ogbulafo had mentioned that, first of all, the storage condition for some of those syrups and the concentration of the anti-malaria molecules, the ACTs in the syrup, because of the dilution, may not be as efficacious as they should be compared to the tablet formulation. So it's better we recommend, the use of the dispersible tablet for those young children rather than the syrup, because sometimes, like she mentioned, the mother may have have not consumed a bottle, left it for 2 or 3 weeks, and another child gets sick, and she goes back and picks it up and starts saying, whether the active ingredients has already been has been dissipated. So they will still use it. And then when they don't get cured, they say, oh, the malaria ACT is not working. So those are some of the concerns that we look at. But whether the tablet formulation, you use it once and it's gone. You just add a little water to mix it up, and you administer it with a spoon or something to the child, and that is the end of that. There is no leftover to be kept. So those are some of the issues why we don't advise caregivers to give syrups. That's right. One. Then the second issue around chemo prevention for young children. Yes, we do have chemo prevention for young children. Seasonal malaria chemo prevention, we use sulfadoxine, pyrimethamine, and amodiaquine for children, but only in those eligible states of the country where you have very seasonal rainfall patterns of where you have the peak transmission season of malaria occurring between 3 and 4 months every year. And after then it's very minimal. So, and that's those regions of the country, mostly in the Sahelian part of the country, is where you have the highest morbidity and mortality from all our surveys. So we have this formulation that's administered to those children 3 months to 59 months to prevent them from getting malaria, particularly severe malaria, which is responsible for most of the deaths. And even when they get malaria, it's usually the milder one because of these 4 cycles every year that's administered to them. So it's given to those children there. Then in the southern part, we are now looking at even piloting intermittent preventive treatment of malaria in infancy. You know, so about 2 states are going to start the pilot. For those children who are not taking that SMC in the Sahelian region, we now want to introduce a IPTI, which is called intermittent prevention for malaria in infants to them. So those are the chemo prevention for those younger age group children. Over, thank you.
Right, thank you, Perpetua. And the questions are also around why are federal and states not using parasitic density for reported malaria in state use +1, +2, +3, +4. I'm sure you'll understand that, but I like what you said about IPTI. We're looking at how we integrate as well in terms of some of those platforms are routine immunization for children and how we tag this on. So this question is around that density. Do you understand why are federal and states not using parasitic density for reported malaria in state use?
In state use, well, I am not, I may not be the right person to answer that question. In state use.
Yes,
yes, you know, the
use.
parasite density is only when you do microscopy that you can get that information, first of all. So, but when you do RDTs, you don't have, you are not able to do that, to report that when you do RDTs. But with microscopy, then you have access, and not many facilities are using microscopy, but maybe Professor Mokulu can also answer that further.
Okay, Prof, there's a question to you. So when we get there, you will take them both on. But before you go, there's one from Hillary.
I also wanted to,
There's one from
wanted
Hillary.
to address the issue from Dr. Shinawo.
Okay, I'll get to,
all right.
I'll get to that. You answer two of them at the same time. Another one, what do you do with patients who have phobia to oral drugs, especially pregnant women who may not adhere to ANC prophylactic anti-malaria? I think the question came 2 times. So that's why I wanted to ask you, yes.
Okay, so I actually had responded live. What I was saying is that
if you have responded, you can skip
maybe some people didn't. Yeah, because what I'm saying is that women take hematinics when they are pregnant, and they are at antenatal care. They are given vitamins and hematinics. That is blood, folic acid, and phosphate. So if they are able to take that, and if the health worker is able to educate them on the dangers of malaria, that malaria in pregnancy poses to both the mother and the child, which there are many, I don't want to go into that now. We all desire a positive pregnancy outcome for the mother and the child. So the health worker should be able to educate them on why it's important that they take it. Just as they take their hematinics, they should be able to take the IPT, the sulfadoxine pyrimethamine, to prevent malaria in pregnancy, because it could result in the stillbirth or death of the child, or even malaria, severe anemia, and so on, and mortality. So the dangers are many. So health workers should be able to convince the mother that just as you need blood tonics to help you have a healthy delivery, you also need this to prevent malaria.
All right, thank you. So you wanted to respond to another question, because somebody is also asking about how do you treat a person who reacts to all malaria drugs, because some reactions are very fatal.
So there are some patients that cannot take some of those anti-malaria drugs, you know, like some who have GPD deficiency and all that, G6PD deficiency and all that, and they can't take some of those anti-malaria drugs. What we advise, in particular for pregnant women, is to ensure that they sleep inside the early lines and do other chemo prevention, other preventive measures to ensure that they are protected from being bitten by mosquitoes. If they cannot take those IPT for prevention, they must then ensure that they sleep inside an early line every night, you know, throughout the duration of their pregnancy, and keep their environment clean, and make sure there are no standing or stagnant standing water around their environment and all that. So those are some of the things we advise for now, you know. So we don't have alternatives to some of those drugs for now, but maybe in the future, alternative to some of those drugs for prevention would come up. Hello? Am I lost?
No, you're not. So the next one is a question, you're not lost. The next one is around what strength would you recommend for the SP plus amodiaquine for use in children between 3 months to 5 years as stated, and also how available are these guidelines that we have made available?
Okay, the
especially
guidelines for now, like Dr. Bulafo mentioned, the soft copy is available on the NMEP website, and we have also shared with the state malaria programs. So, but we have not printed hard copies for now due to funding challenges. So when we do print hard copies, we usually distribute to the state malaria programs as well. But for now, the soft copy is available on the NMEP website. People can access that, and every opportunity we have, we use it to disseminate, to share those guidelines with health workers. So the state malaria programs all have soft copies of the guidelines, and they can also share it further down the line to local government and health facilities. I mean, the soft copies for now, until we print the hard copies.
Okay.
And then for the strength, said something about the strength. No, so those medications for children are given according to body weight, and all the health workers are usually trained on that. Yeah, on the administration by body weight.
There was a question you wanted to answer before. There was a question you wanted to answer before I took you off. You said you wanted to respond to.
Okay, Dr. Shunawa said that for the urine malaria testing, that they're looking to the national for guidelines on data collection, how to capture, because if you look at the data, the HMI data we use, the tools that we are using now for capturing malaria diagnosis and treatment at health facilities, it doesn't have this. It only has provision for RDTs or microscopy. But that guidelines are reviewed usually every 2-3 years. So the last one was reviewed in 2019. So I'm sure that by the time the program has gone through the processes of including in the national guidelines, then it will also be factored into the data collection tools. And then so that when people, states are using it for reporting, they would have provision for capturing it in the national tools that are used for routine malaria diagnosis and treatment. So we are still in the process of working with those who have produced this new tool, this urine malaria testing, to make sure that all the due process have been followed, and then we can it become part of the national guidelines, and trainings will be done accordingly as well, and data collection provision will be made for them to report it as well.
Yeah, right. So because there's a question from Berechi Mercy on that UMT, but before we do that, thank you, Perpetua, for yours. And then we'll continue to look at other questions that are coming, but these are the questions we can take now. But there's a question to Dr. Wellington. Please, do you think comorbidity is responsible for incessant lab results of malaria and typhoid? Positive. There was also a question around Widal and malaria. So that question that goes to Dr. Wellington, and the other one will be going to those on UMT. Dr. Wellington, are you here? Professor Wellington, are you here to take that question?
Yes, thank you very much. I'm here. Thank you, moderator. So when you have what you call incessant malaria, that means you keep on having malaria, or what? But let's provide the kind of hypothetical explanation to all of this.
Incessant lab results.
Oh, incessant lab results, whether it's due to comorbidity or not.
Yeah. Malaria and typhoid.
Okay. Now, there are situations where the lab results, if it's by microscopy, may not be correct. And if it's not correct, we have seen too that just to have something in the results, we have some untoward practices. So you see malaria included. And the same thing too for typhoid, because the test for typhoid really in some places is not properly done. So the likelihood too is that because of that lack of capacity, you still find positive Widal cases. In our medical center, where we still see about 50,000 students, in the past 5 years, we only have had one case of typhoid treated in the University of Lagos Medical Center. 1 case of typhoid treated. So of course, in that same vein too, there are challenges in the malaria diagnosis. So when you say instant results, it just portrays the level of quality that goes into doing those tests. So, and that's the kind of confusion you see coming. How much of the typhoid positive results should you have? The indication is that typhoid is even still overdiagnosed, to be truthful, it's still overdiagnosed. And the same thing with malaria. So when the quality platforms are not available, the right capacities are not there to do it, you really will have some of these confusing results. So ordinarily, for you to rule out or to rule in, you do the real tests, have that capacity, have the infrastructure, and still be able to, to have surrogate tests to use. So that's what we can use. I can explain with those. So it's a lot of garbage, a lot of confusion coming because of those due process. And just to mention too that we're looking at why we're having these challenges from the lab. One of the reasons, because you cannot continue to build capacity by diseases. You build capacity for malaria. You build capacity for HIV. You build capacity for tuberculosis. You have so many diseases to build capacity. So one of the things we have seen here is that labs should really function with quality processes, which means that laboratories should be accredited. You have the clear accreditation for the ISO for laboratories. You're either using ISO 17025 or the 15139. And once you achieve that level of quality, no matter the kind of disease, there's a responsive system that is put in place. Thank you very much.
Right, thank you so much. So I think that wraps most of the questions I have, except for one around the availability of the urine test kit. How available and how accessible is it? And somebody also wanted to see how it is used, and it comes from Mercy Berechi. How available and accessible is a urine malaria testing kit, and the urine to be used? Is it to be produced instantly or early morning urine? So
I can answer that.
Okay,
please.
Go ahead.
So thank you very much. The urine malaria test is available. We did the clinical trial, and I know the manufacturers' reps are in the country. The urine malaria test is available in community pharmacies and in a number of medicine retailing shops. Now, in terms of use, no reagent is required for the urine malaria test. So it's just a strip, and you just need a very little quantity of urine. And you can have that urine at any time, really. So it doesn't need to be early morning urine. Anytime you can do that test. So in the pack, there's a container that comes with it. You have that volume of urine, and you simply put the strip. And within 20 minutes to 25 minutes, you'll be able to read out the results. So unlike the blood-based RDTs, where you have to put a buffer, you have to do other steps, it's just a one-step procedure and pretty easy. And you see the next line coming after the control, and that indicates whether it is positive. If no other line comes after the control, it means it's negative. So that's how it works. And it's all antigen capturing, like the blood base. So it captures the antigen, the HROP2 antigen in the urine. Thank you.
Thank you very much, Professor Wellington. I've highlighted the issue of verticalization and how we continue to use multiple resources instead of pulling together and integrating in terms of capacity building. Issues of capacity has also been drawn here during the presentations, but I think it's time for me to call it a day. But I want to remind us of a call to action: the risk of increased malaria morbidity and mortality as raised by the National Malaria Elimination Program, the economic losses following years of malaria, and the weak workforce with reduced productivity, and of course, loss of confidence in our public into what we do. These are the things they've asked us to work together. What we must do as individuals, in our practices as a private sector, even as we see NESH doing today, it is most appreciated. It's been a pleasure moderating this session. I've learned a lot. I'm going to look for a lot of presentations and I'll read up a lot more on malaria and what I, as a person, not as a moderator, on my desk as the Director of Community Health Services will be doing towards malaria control. Thank you very much. Over and back to you, Anko.
Thank you very, very, very much, Dr. Nneka Onwu, the Director, Department of Community Health Services of the NPHCDA, the National Primary Healthcare Development Agency. Amongst the panelists was a star-studded panel. We had Dr. Ahmad Abdul Wahab, Senior Health Advisor, Nigeria Governors Forum. Dr. Okunz Ohio Simuan, Corporate Medical Services Manager, Nigeria LNG. Dr. Bimbo Oshinawa, Lagos State Rollback Malaria Program. Malam Yusuf Mohammed, the Kaduna State Rollback Malaria Program. We also had Professor Wellington Oibo and Professor I'll come back to that. Meanwhile, it's time to take an interlude from our sponsors, 2-minute interlude, advertisements on malaria-related products from our sponsors. Thank you while we cut to the interlude and the adverts. Can we have the interlude from our sponsors? Also, Mokwolu has had to leave for an examination. The training goes on regardless. This is a
we don't introduce the all new urine malaria test, where they call UMT, the first and the only non-blood dipstick, where if you take test for malaria within 25 minutes, you go check whether na fever or na malaria they do you. No blood, no pain, now just small drop of urine where you need. How this UMT strip take the work? Number one, you go deep test the strip inside one small cup of urine. Number two, may you wait small for that kind of 25 minutes or less. Then number three, if you see 2 lines, that be say you get malaria. If now one when you see, that be say no malaria there at all. But if you not see any line appear, that one mean say the test not correct. So you go take another strip, make you do another one.
Children are gifts and the source of joy. When they are happy, we're happy too. But when they are down with sickness such as malaria, we become sad and worried. Not to worry, Camosunate anti-malarial for children has always been there for years. Camosunate also comes in tablets for adults. Bounce back from malaria with Camosunate. Confirm if Camosunate is original by texting to read the leaflet inside. If symptoms persist after 3 days, please consult your doctor. Camosunate, effective anti-malaria for all ages. Marketed by Zenith Pharmaceuticals Limited.
Shebi you say you dey find hope.
Thank you very much from our sponsors for supporting us in this journey of bringing proper malaria care to everyone in this great country of ours. We've heard a lot about malaria. I thought I knew a lot about malaria, but I realized that this has been an update course, full update course on the management and care of malaria fever in the 21st century, in fact, in 2021. As much noise as was made about COVID-19, malaria has killed more people than COVID-19 since the pandemic began. So we actually have an ongoing malaria pandemic at all times for the past, from time immemorial. It's been ongoing, and people continue to succumb to this dreaded illness. I hope that one day we will see the back of malaria, starting from Bonny, with the assistance of the NLNG. We have learned about the cost, 1.9 trillion. We've learned about the criminal activity of using monotherapy for caring for malaria. We've learned that 27% of the global disease burden of malaria is resident with us here in Nigeria. We've also learned that 23% global deaths of malaria, a full quarter of deaths, is also occurring here in Nigeria. These are dreadful statistics, and it behoves us all, whether or not we're in the medical industry, to put all hands on deck to save us from this great scourge. I now have the pleasure of calling upon none other than the National Coordinator of the Malaria Elimination Program, Dr. Perpetua Homoibi, to give us the vote of thanks as we wrap up this excellent, well-conducted, full program we have had today. Dr. Perpetua Homoibi, you have the floor.
Hello? Hello?
Yes, we can hear you, madam. Carry on.
Hello, can you hear me? Okay, I'm sorry. Okay, all right. Yeah, thank you very much, Mr. Moderator. On behalf of the National Malaria Elimination Program, Federal Ministry of Health, I want to sincerely appreciate the organizers of this summit, Mr. Emeka, who I can't pronounce, I'm sorry, I can't pronounce the second name, the founder of NESH, Nigeria and Entrepreneurship Summit and Honors, for really organizing this workshop. It's more or less has become a yearly event, and we truly appreciate the collaboration and partnership with your organization, sir. And I also want to appreciate the Permanent Secretary, Federal Ministry of Health, my boss, who graciously also graced this occasion with his open remarks, as well as the Chairman Senate Committee on Health. I want to appreciate all the presenters, all the partners, presenters, the facilitators, and all the moderators who have been following this summit for more than 3 hours now, I must say. It shows how exciting this was for everybody and interesting for everybody. I really appreciate all of you for this dedication. We are all committed in the fight against malaria because we do recognize that malaria is not only a health and public health issue, it's also a developmental issue for the country. We cannot continue to bear the burden of being the highest, with the infamous honor of being the highest burden country for malaria in the world, in the global, and also in the sub-Saharan Africa and in the world in general. We have to change that narrative. And the only way we can do that for all of us to come on board and make sure that we do the right thing in terms of diagnosis and treatment of malaria, and also promote people to test before treatment. We cannot stress that, so that we can have accurate data for what is being reported, so that not too many people are treating all fevers for malaria and it's reported. It has implication for us as a country. So we need to start to do the right thing, and all hands have to be on deck, including the private partnership with us, to ensure that even in the private sector, they are doing the right thing. The fact that people the patients say they want, once they know it's fever, they know it's malaria, and then some of us say we want to not to show that we are not good clinicians or good health workers by giving them what they want, but then it's bad practice, and we should not continue to promote bad practice. If it's not malaria, we must have an algorithm for what next to do to make sure that the patient gets treated appropriately. So once again, I thank every one of you for this, particularly the organizers, and I wish you all a wonderful afternoon. Over. Hello, over to you. Thank you. I hope you heard me. My network.
Thank you very much, Dr. Perpetua Umohebe. We heard you loud and clear. We thank you. You are the lead in this great project, and we pledge to follow your lead. Ladies and gentlemen, it is with a little bit of regret, because I would have loved to learn more, but with appreciation for all who attended, that I wish, on behalf of the organizers, to bring this session to a close. And to do that, I will call upon us all to virtually stand as we take the national anthem. Thank you all. God bless you.
say you dey find ogbonge and reliable way make you take test for malaria, oya, no shake go front again. We don introduce the all-new urine malaria test wey they call UMT, the first and the only non-blood dipstick wey you fit take test for malaria. Within 25 minutes, you go check whether na fever or na malaria dey do you. No blood, no pain, na just small drop of urine wey you need. How this UMT strip take dey work? Number one, you go deep test the strip inside one small cup of urine. Number two, may you wait small for that kind 25 minutes or less. Then number three, if you see two line, now be say you get malaria. If now one when you see, now be say no malaria there at all. But if you not see any line appear, that one mean say the test not correct. So you go take another strip, make you do another one.
Children are gifts and a source of joy. When they are happy, we're happy too. But when they are down with sickness such as malaria, we become sad and worried. Not to worry, Camosunate anti-malarial for children has always been there for years. Camosunate also comes in tablets for adults. Bounce back from malaria with Camosunate. Confirm if Camosunate is original by texting to read the leaflet inside. If symptoms persist after 3 days, please consult your doctor. Camosunate, effective anti-malaria for all ages. Marketed by Zenith Pharmaceuticals Limited.
Shebi you say you dey find ogbonge and reliable way make you take test for malaria, oya, no shake go front again. We don introduce the all-new urine malaria test wey they call UMT, the first and the only non-blood dipstick wey you fit take test for malaria. Within 25 minutes, you go check whether na fever or na malaria dey do you. No blood, no pain, na just small drop of urine wey you need. How this UMT strip take dey work? Number one, you go deep test the strip inside one small cup of urine. Number two, may you wait small for that kind 25 minutes or less. Then number three, if you see two line, now be say you get malaria. If now one when you see, now be say no malaria there at all. But if you not see any line appear, that one mean say the test not correct. So you go take another strip, make you do another one.
Children are gifts and a source of joy. When they are happy, we're happy too. But when they are down with sickness such as malaria, we become sad and worried. Not to worry, Camosunate anti-malarial for children has always been there for years. Camosunate also comes in tablets for adults. Bounce back from malaria with Camosunate. Confirm if Camosunate is original by texting to read the leaflet inside. If symptoms persist after 3 days, please consult your doctor. Camosunate, effective anti-malaria for all ages. Marketed by Zenith Pharmaceuticals Limited.